Good afternoon, ladies and gentlemen. My name is Thuy, and I'm from Vietnam. I'm the head ingredient of the Department of Nutrition and Food Safety at the Institute of Public Health in Ho Chi Minh City. And it's my honor today to share with you a paper just published in BMC Medicine 1 month ago. Our research is about the prevalence and associated factors of complementary feeding practices in rural disadvantaged areas in Vietnamese Mekong Delta. So my presentation will cover the math 5 parts as a structure of research. The WHO has defined complementary feeding practices as a process by which an infant begins to consume foods and liquids along with breast milk as the nutritional needs are increasing with age. And appropriate complementary feeding practices are important for children's health, growth, and outcome due to their long-term influence on the child's survival and nutritional status. During the period of 6 to 23 months, children who are consuming adequate complementary foods may be at greater risk of malnutrition. And malnutrition is the main cause of morbidity and mortality for especially children under 5 years of age, and it is responsible for 45% of the child death. In Vietnam, 19.6% of children under 5 years of age were stunted, and 5.6% of children under 5 years was wasted. And the prevalence of malnutrition in the Southwest is higher than the average number of the country. Especially in the isolated areas like Bang province where our study is conducted. The WHO and UNICEF has developed several indicators for monitoring global infant young child feeding practices indicators and for the consistent national comparisons. According to that, it includes 3 main indicators, including minimum dietary diversity, minimum meal frequency, and minimum acceptable diet. According to that, the minimum diet diversity refers to children from 6 to 23 months of age who consume foods and beverages, at least 5 out of 8 food groups in the preceding day. And the 85 food groups include breast milk, grains, and cereals, pulses, nuts, dairy products, fresh foods, and vitamin A rich and vegetables and other fruits and vegetables. Minimum meal frequency refers to children from 6 to 28 of a month who consume solid or semi-solid or soft foods at least the minimum meals of time during the day. For specifically to 15 breastfed children aged from 6 to 8 months and 3 feedings for the breastfed children from 9 to 20 months. For the non-breastfed children, at least 4 feedings, and with at least 1 of the 4 feeds must be solid, semi-solid, and soft foods. Regarding the minimum acceptable diets, it is the combined indicator of minimum diet diversity and minimum meal frequency. So this graph shows that the infant young child feeding indicator is in Vietnam, reported in the national survey conducted in 2020 and 2021. So as you can see that the prevalence of the minimum meal frequency at about 78% and the minimum dietary at about 55%. And minimum acceptable diet is very low at about 45%. And there is a little bit difference between the minimum acceptable diet between the breastfed and non-breastfed children. In addition, about 20% of children who did not consume adequate vitamin A rich foods such as eggs or orange fruits and vegetables. So, the global and national context indicators in young child feeding is very important for the children's nutritional status and health. And indicators in young child feeding practices in Vietnam is problematic and need to be improved to reduce malnutrition for the children. So, however, most of the research in Vietnam is currently focused on the northwest of the region. And the Southwest, like in the Vietnamese Mekong Delta, we have limited studies on infant young child feeding practices. In addition, since the WHO indicators about infant young child feeding practices were modified, there is limited studies on this to explore the magnitude as well as associated factors, especially limited studies on the complementary feeding practices and household food insecurity, water sanitation and hygiene, and food environment awareness. That's why we decided to conduct a study on to identify the prevalence and associated factors of complementary feeding practices, especially the child maternal household characteristics, household food insecurity, water sanitation and hygiene, and food environmental awareness. So this is the map of my beautiful country, Vietnam. So it looks like the letter S, and this is the Vietnamese Mekong Delta, and this is the place where our study was conducted, which is a rural disadvantaged area. And Thanh Phu district of Ban Tra province were designated as economically disadvantaged area by the Prime Minister every year, annually. And totally we have 558 child pairs after excluding incomplete data. This photo we took at the field when we collected the data. You can see, this is our staff. He's the nutritionist of our department, and he's weighing and measuring the weight and height for the children. And we conducted face-to-face interviews with the mothers about the infant young child feeding practices. So we use a structured questionnaire adapted from previous national and international studies. We collect data on child maternal household characteristics, household food insecurity, water sanitation and hygiene, and food environment awareness. We conducted pilots to test it, and after that we modified the questionnaire for local language. Our main outcomes were 3 complementary feeding practices, including minimum dietary diversity, minimum meal frequency, and minimum acceptable diet. And our covariates and child characteristics, health nutritional status of children, and maternal characteristics, as well as household food insecurity, we measure by the food insecurity experiments scale. For the food environmental awareness, we use 6 questions to ask about the availability, accessibility, quality, and prices of foods. For example, we ask about the respondent opinions about food shopping place, whether there are good quality foods near your residence, or whether food prices are reasonable, and there are various fresh vegetable and fruits nearby. For wash indicator, we explore the sanitation facility, hygienic facilities, hand washing facility, and hand washing practices. We follow the definition and categorization of the UNICEF on the progress on drinking water sanitation and hygiene in 2007. However, we generated a new variable, which is about the drinking water treatment with 3 categories, including point of view treated, POUT, household boiled water irrespective of its source, and outside treated household use bottled water or pipe drinking water but did not boil before use, and untreated drinking water, household use untreated water from river, canal water, rainwater, or tube well or drip well water, and did not boil before use. We care about the quantity of the water because there are some evidence pointing out that the quantity of the water in the Vietnamese Mekong Delta is low, and it is because of inappropriate agricultural practices and the habit of using rainwater electrically for eating and drinking, and the quantity of piped water or rainwater is low. So that's what we care about that, and we use the boiling water before use as a standard, because this is the most commonly used treatment water for drinking water before use. Yeah. So we use the AB data, AB and STAR for data entry and analysis. And bivariate association were assessed using the t-test and fast-test test. And multi-association were evaluated by backwards logistic regression. We get the ethical approval from our institute and local commission, as well as the consent from the participants. So overall, we got the data from 358 models of fevers, and most of them were from the ethnic majority ethnic group. In Vietnam, we have 54 ethnic groups, and the kin accounted for about 85%. And the 53 ethnic groups, including Chinese, Khmer, accounted for about 15%. So most of our participants have no religion, and they aged from 21 to 40. They were married and they had medium to high educational level. Half of the mothers were housewives or unemployed. On average, there are 5 people in the house, and 87% of the household had monthly income more than 5 million Vietnamese dong, which is equals around 194 US. Regarding the household food insecurity status, the proportion of household experiencing household food insecurity is about 37%, which is remarkably higher than the national proportion. And in which we have 8% of the households still experiencing moderate food insecurity, and 2.2% experience severely food insecurity. This graph shows the food consumption in the previous day by the children. And as we can see that the most commonly used food groups including grains and fresh foods, as well as vitamin A rich food and vegetables. And however, just only 41.1% of children were breastfed. And the proportion of children who received rabies nuts in the previous day was very low, as well as eggs and other fruits and vegetables. Yeah. Regarding the complementary feeding practices, you can see that the percentage of children with adequate minimum acceptable diet just very low, 31.6%, and the percentage of children with minimum meal frequency about 40%. This graph we compare the complementary feeding practices between non-breastfed children and breastfed children. As you can see, the percentages of non-breastfed children with adequate minimum acceptable diet is 7% compared with 24%. Or around 25%. Similarly, we find that the percentages of children with inadequate minimum meal frequency was significantly lower in non-breastfed children compared to breastfed children. Yeah, 10% versus 13%. And these tables review some associated factors of complementary feeding practices. So we found interesting results. For example, we see that the children aged from 18 to 23 years old had higher minimum diversity compared to children from 6 to 11 years old. And in contrast, we found that children aged from 18 to 20 months had very low, had lower minimum meal frequency compared to children from 6 to 11. In addition, we found that children who were sick in the last 2 weeks had lower minimum diet diversity compared to children without sickness. And importantly, we found that children whose fathers were their primary caregivers had extremely lower minimum diet diversity compared to children whose mother were the primary caregivers. I don't know whether the gentleman down here agree with that results or not. Yeah, we found that if children whose their fathers is primary caregiver, they have higher risk of being less adequate minimum diversity. And surprisingly, we found that children whose their primary caregivers, single or divorced, has higher minimum acceptable diet compared to children whose their primary caregivers married. Also, we found that children who were breastfed had a better minimum acceptable diet, also minimum diversity and minimum meal frequency. And we also found household food insecurity and monthly income related with the minimum acceptable diet. And what distinguishes our result from other previous studies is that we found a significant association between the percentage, the association between using untreated drinking water with poorer MTD, minimum diversity. And lastly, we found that children whose their mother often bought food at the street vendor shops had higher minimum meal frequency compared to children who had their mother bought food at the traditional market. So these are the common street vendor shops in Vietnam, especially this one in the Vietnamese Mekong Water. So we found that the minimum acceptable diet and minimum meal frequency in the rural disadvantaged areas was significantly lower than the national reported numbers. And this indicates that the infant trafficking practices in the rural disadvantaged in Vietnamese Mekong region need to be considered. It may be because that the malnutrition is more serious in the northwest area, so many efforts is placing in this area and overlooking the other regions such as the Vietnamese Mekong region. And regarding the children aged from 18 to 23 months and those who were not present had lower adequate minimum meal frequency, it can be explained that due to the misconception that the children who age from 18 to 20 months, they are older enough to share the same food and the same meals with the adults in the family. And maybe because mother has to stop to return to work, so neither there is sufficient time to feed their children more frequently. And children from 6 to 18 months had worse minimum diversity compared to the children from 18 to 20 months because parents consider children at this age too young to feed a variety of food, and they are afraid of feeding their children, especially the seafood or the nuts, because they worry about the choking or the allergies. So we recommend that education and communication program on complementary feeding should emphasize the importance of providing children with adequate meals and a diverse range of foods according to their age. And based on other findings regarding the associated factors of complementary feeding practices, we suggest that the nutrition, education, and communication should engage male caregivers, especially the fathers and the grandfather, into the child nutrition program. Yeah, especially in the rural areas, father and grandfathers involved in feeding or taking care of children very much. The child nutrition program should promote breast milk and especially pulses and eggs and fresh vegetables in rural areas because these are very cheap foods and they are available and accessible for every family, especially the poor family. Yeah, they are very cheap in rural area in Vietnam. And we should emphasize the importance of breastfeeding and integrate breastfeeding into the complementary feeding practices because now the breastfeeding prevalence is very low, which is about 1%, and we want to improve that. Yeah. And the child nutrition program may consider and enhance the role of the street vendor shops, especially in the rural areas, to improve the minimum meal frequency as well as the diversity for the children. Because in the rural areas in Vietnam, we don't have much traditional markets. So one commune or one district, we just only have one traditional market. So its mother must transfer very far to buy food for the children. So street vendors may improve complementary feeding practices. So regarding the association between untreated drinking water and poor minimum diversity, we can explain by the economic pathway and awareness of the mothers. Maybe because in the Vietnamese Mekong Delta, poor families don't have enough container water to keep rainwater. And maybe because the household in the Vietnamese Mekong Delta using untreated drinking water are usually food insecure. So poor mothers and caregivers have to fetch or collect water for household, so limiting their time for feeding or preparing a variety of food for their children. And the wealthy or highly educated mother, in contrast, they can have greater awareness and knowledge about the importance of nutritious and safe food and water. But so they care about that and they take care of their children better. However, it's just a cross-sectional study, so we recommend further research to explore this association. So in conclusion, in a broader complementary feeding practices is still problematic, especially in rural disadvantaged areas in the Vietnamese Mekong Delta. And giant age household food insecurity, use of untreated drinking water, as well as money income and breastfeeding and source of purchase food were associated with complementary feeding practices. So these underlying causes should be addressed to improve the complementary feeding practices in rural disadvantaged area in the Vietnamese Mekong Delta. Thank you very much. And teachers, cảm ơn, this is Vietnamese language. And this is my little daughter with me. We have coffee together at the weekend. Yeah. And I follow how to feed my child by using the guidelines of WHO or UNICEF. And I see she's progressed very good. Yeah. Thank you very much.